don't see anybody else joining, so it is my absolute pleasure to introduce Dr. Anne-Marie Laberge. Dr. Anne-Marie Laberge is not only a superb clinician and scientist, she's also a dear friend. She is a full professor of clinic at the Department of Pediatric at Université de Montréal and the department head for the genetics department at Saint-Justine. She has a full clinical practice, including aortopathies, where she shares her time between the Montreal Heart Institute and Saint-Justine Hospital. I can keep talking about all that Anne-Marie has done for a very long time, but maybe it is better that I let her speak. So over to you, Anne-Marie.
Thank you, Julie. Can you see my slides? Yes, okay.
Yes.
Small corrections, so our genetics is a division here, not a department, but yeah, other than that, thank you. Julie asked me today to talk to you about the implications of genetic testing beyond the care of relatives and really for the management of the patient. I have no conflict of interest. So the objectives today are to describe the implications. Just trying to minimize the screen here. It's not working. Okay, let me do this. Okay. So describe the implications of a genetic diagnosis for patients with aortopathy and the main issues around genetic testing. So
thanks so much for calling. Cheers. Bye. I knew I was meant to get something else to.
Anne-Marie, you're muted.
Okay, sorry. So just a reminder that 20% of non-syndromic thoracic aortic aneurysm are related to a genetic condition. Different terms are being used. HTAD refers to hereditary thoracic aortic disease. Genetic aortopathy has a causal genetic defect. It can be inherited or it can be de novo, so a new mutation. Once someone has a genetic aortopathy, they can transmit it to their children. If there are multiple related individuals with an aortopathy in a family, then it is a familial aortopathy, whether or not we have identified a genetic cause. Syndromic aortopathies have multisystemic features outside of the aorta, but often involve the aortic root. And so non-syndromic HTAD use that as a synonym to FTAD, to familial thoracic aortic disease, but really it is a limited involvement of the aorta and its branches. Sorry, I was disturbed by the noises. Okay, so what are the implications of genetic testing for your patients? So genetic testing and a genetic diagnosis can help guide the management of your patient's aortopathy, guiding surveillance, type of imaging to be done for the surveillance, the choice of medication, and the surgical threshold. And in patients with syndromic aortopathies, it can also guide the management of other cardiovascular manifestations outside of the aorta, and also guide the management of non-cardiovascular manifestations. So a short case to start. A 27-year-old woman with aortic dilatation with a root at 41 millimeters, who has had a clinical diagnosis of Marfan syndrome since childhood, whose mother died from acute type A dissection in the postpartum period. She has no other affected relatives. She has never had genetic testing. She has had a pregnancy that was managed according to guidelines for Marfan with no complications. And you're now seeing her with her 18-month-old daughter, who is referred to assess whether she inherited her mother's Marfan syndrome. So, is there an indication for genetic testing? Well, of course, to assess the daughter, it would help if we had familial mutation. When you see the daughter, she also has an aortic dilatation, and because she has the aortic dilatation and a family history, she meets the clinical diagnosis criteria for Marfan syndrome. So if you have a clinical diagnosis for both, one could ask, well, is it really relevant to look for the mutation? Um, so so those are the criteria to say that she meets clinical diagnosis. But when you examine the daughter, you see that she has a bifid uvula, which suggests Loeys-Dietz syndrome instead of Marfan. And the patient also has a bifid uvula. So then it becomes more interesting to differentiate between Marfan and Loeys-Dietz. So genetic testing identifies a pathogenic variant in TGFBR2, which is the gene involved in Loeys-Dietz syndrome. And this is a story that we see fairly regularly. Adults who have had a long-standing clinical diagnosis of Marfan syndrome, who in fact have Loeys-Dietz syndrome. And this genetic diagnosis will guide surveillance for both the mother and the daughter. The frequency of echocardiography is the same for Marfan and Loeys-Dietz, but there's broader imaging to be done for Loeys-Dietz than in Marfan. And so patients with Loeys-Dietz syndrome will require imaging beyond the aorta with CT or MRI. And then in terms of the surveillance, as I said, patients with Loeys-Dietz require more extensive imaging than other aortopathies because they're at risk of dilatation of other arterial branches. So for this patient with Loeys-Dietz, she requires yearly TTE, as we said before, and also CT and MRI, a baseline MRI or CT from head to pelvis to evaluate the entire aorta and its branches, and then every 2 years. And then genetic diagnosis will guide the choice of medication, although both beta blockers and ARB are recommended for Marfan syndrome and LDS. We know that calcium channel blockers are generally avoided. And then in this case, if the patient's aortic dilatation is progressing, treatment with both beta blocker and ARB could be used. One big difference is the impact of the genetic diagnosis on the surgical threshold. This patient has initially, in the first guidelines, the surgical threshold for patients with LDS was 42 millimeters for all genes involved. Now the recommendations are based on which gene is involved. She has a mutation in TGFBR2. With high-risk features such as a bifid uvula and a family history of dissection. So the threshold in her case is 4 centimeters, which is different than what it would have been for Marfan. So these are just to show you that there are a lot of recommendations about threshold that are based on the gene involved. So other than Marfan, also different thresholds for ACTA2 and PRKG1. A genetic diagnosis also has an impact on the surgical threshold for the descending thoracic aortic aneurysm, and the patient with Marfan Loeys-Dietz or vascular EDS who develops a descending aneurysm has a higher likelihood of rupture, so they need to be followed more closely. The genetic diagnosis also has implications for the choice of surgical approach. In this case, in patients with both Marfan and Loeys-Dietz, as well as vascular EDS, open repair is recommended. And then, of course, implications for the patient's future pregnancies, not only in terms of the transmission of the condition to her children, but also in terms of the pre-pregnancy evaluation. In terms of future pregnancies, the surgical threshold before pregnancy also varies based on diagnosis. So in her case, she was at 41 millimeters with the diagnosis of Loeys-Dietz syndrome. She would be in the range for a prophylactic aortic surgery before her next pregnancy. Outside of the aorta, a genetic diagnosis has implications for non-cardiovascular care. These are the now kind of old guidelines about the management of Loeys-Dietz syndrome, about orthopedic care, allergies, gastroenterology, and nutrition. New guidelines are in the works and should come out within the next year, from what we hear. So because of these implications, a genetic diagnosis is important. The question remains, do you need a genetic test to make a diagnosis? Well, not always, but it's often difficult to completely distinguish clinically between Marfan and Loeys-Dietz syndromes. One big difference is the presence of lens dislocation, which is almost always Marfan syndrome, but other than that, it can be really hard to distinguish. The absence of family history does not rule out a genetic etiology. There's a significant proportion of patients who have de novo mutations. It varies based on the diagnosis, but it's not rare. So when should you be considering genetic testing? There are a lot of features that should prompt a referral to genetics or a consideration of genetic testing if you feel comfortable doing it yourself. When your patient has a TAA or TAD at a young age, when your patient has aneurysms or dissections in other arteries or arterial tortuosity, when your patient has multisystemic features suggestive of a connective tissue disorder, or when your patient has a family history in first or second degree relatives of dilatations, aneurysms, or dissections, or sudden cardiac death before age 50. When is genetic testing not recommended? So typically, we would not offer genetic testing if thoracic or aortic disease is diagnosed after 60 years of age without a family history or features of a connective tissue disorder, or if it's diagnosed before 60 years of age, but with a documented atherosclerosis on pathology or a significant hypertension. So these would be considered not sporadic and therefore not likely to be genetic. And we would not typically offer genetic testing in a patient with a normal aorta and a family history of dissection, especially if the index case or so someone who has had an aortopathy in the family is available for testing. We would test an affected person first. There are a lot of genetic causes of aortopathies. The most common are Marfan, Loeys-Dietz, and vascular Ehlers-Danlos syndromes, but there are many other rare and ultra-rare conditions. Non-syndromic hereditary thoracic aortic disease can be due to variants in some of these genes that are associated with syndromic forms, but in some patients, such variants in these genes are not associated with connective tissue disorders or connective tissue features, or they may be very mild. So a lot of aortopathy panels combine the syndromic and the non-syndromic, the genes for the syndromic and the non-syndromic forms in the same panel. So what type of genetic test should you use? Single gene testing typically is used when you really have features of a specific, very typical of a specific diagnosis. So someone who has a lens dislocation, for example, it could be justified to just look for Marfan syndrome. When you have a known familial variant, usually you just look for that and you don't do broader testing. But you still might use the target panel in some cases when you have a very specific presentation, but more and more people will be using multi-gene panels, either for syndromic aortopathies or non-syndromic familial aortopathies. These are the number of genes in our panels at the Montreal Heart Institute. Some centers just have an aortopathy panel with all of those genes all together. If you look at the ClinGen Actionability Adult Summary Report, which is ClinGen is an American organization that looks at the evidence supporting the actionability of phenotypes related to specific genes. Only 9 genes have strong actionability for FDAD. So all panels will include those 9 genes, but some of them will include other genes with less evidence. Exome or genome sequencing is not available in all provinces, is usually prescribed by a medical geneticist, and will only be used for patients with no diagnosis based on the usual panels and really severe or atypical phenotypes. Genetic testing should always be done with pre-test counseling and informed consent. The diagnostic yield is 20 to 30% in non-syndromic HDAD and much higher in syndromic HDAD, but don't hesitate to refer to a subspecialist or a specialized clinic if you're not comfortable doing that yourself. Be careful how you use genetic tests. You can discuss with a geneticist or refer the patient. There's a risk to misinterpreting genetic test results, which may include delaying a diagnosis, falsely reassuring a patient or their family if you misinterpret a result, and misattribute risks of aortopathies or dissections if the results are misinterpreted. For those of you who use genetic tests, you are familiar with the terms pathogenic or likely pathogenic variants or variants of unknown significance. Variants of unknown significance don't confirm or eliminate a diagnosis, so management decisions should be based on the clinical presentation and the family history, and then the variant should be reinterpreted at a later date. A negative test result reduces the likelihood of a genetic diagnosis, but does not completely exclude it, because we know that there are cases where we don't know the genetic basis yet. So a second case, just to finish and wrap up, a 55-year-old man followed for aortic aneurysm at 42 millimeters at the root initially, and now at 47. Not a lot of systemic features, inguinal hernia repair, normal blood pressure, normal cardiac exam. Should we offer genetic testing? Well, he is under 60 with no obvious risk factors, rare signs of connective tissue disorders, and no family history. So it's an isolated non-syndromic aortopathy, but because he's at a young age, we offered genetic testing and found likely pathogenic missense variant in FBN1 on our panel. So now this has modified his diagnosis and changes the frequency of the surveillance and the surgical threshold. So take-home messages are that a genetic diagnosis has implications for the care of patients with thoracic aortic disease in terms of the frequency and the modalities of surveillance, the choice of medications, the surgical thresholds, and approach pregnancy management and non-cardiovascular care. Not all patients with thoracic aortic disease require genetic testing, but testing according to recommendations will help identify those who have an underlying genetic diagnosis and ensure they are getting the appropriate care. And if you do use genetic testing, be careful how you interpret the results and seek the advice of experts if you're unsure. Thank you.
Thank you so much, Anne-Marie. This was fantastic. Before we move to the next speaker, is there any burning questions for Anne-Marie? It seems, Anne-Marie, that it was super clear. There might be question in the context of the plenary if you're willing to stay with us. So Munir, over to you.
Fantastic. Yeah, absolutely. Our next speakers, it's actually a tag team effort and quite an interesting perspective, both a patient as well as a clinician or surgeon perspective on life after aortic repair. So the patient perspective will be presented by Dr. John Veinot, who is a retired pathologist, who himself has suffered from aortopathy. Dr. Veinot is a cardiovascular pathologist, worked at the Ottawa Hospital, CHEO, and the University of Ottawa Heart Institute. He is the past president of the International Society of Cardiovascular Pathology. Excuse me. He did his undergraduate training at Acadia University, medical school at Dalhousie, and internship at Victoria Hospital. He did a residency in anatomic pathology at Queen's University and completed a fellowship at the Mayo Clinic. He's been the chairman of the Department of Pathology and Lab Medicine at the University of Ottawa. He's retired since December of 2022. And our second speaker, who I'll introduce now so that they can transition more easily, is Dr. Ming, who is an assistant professor within the Division of Cardiac Surgery at the University of Ottawa Heart Institute. Ming has completed his residency in Ottawa, but fellowships in Paris and at the University of Pennsylvania and Philadelphia, and comes back as an aortic surgeon, aortic disease expert within the division. So I'll hand it over to John to start, and then for Ming to follow.
Well, thank you very much for the opportunity to speak today. It's a pleasure to do so. I'm just going to attempt to share. Can anyone see my slides?
Yes, we're good.
You can? Great. So I'm presenting today as a patient, although it's hard to remove the fact that I've been an MD for almost 40 years, and that doesn't really wash off or disappear. And it makes me probably more of a challenging patient than others. So apologies to all who have ever had anything to do with me. I have no disclosures aside from that. And I know a lot about aortic dissections. And here's one, for instance, with the true lumen here, the false lumen here. But I'm not going to talk about pathology. I'm going to talk about me. So this is my story. In 2011, when I was 48 years old, I just came back from a hospital meeting, was sitting down having, a nice bowl of soup, watching Big Bang Theory, when I felt basically the great big axe in my back. This was followed shortly by nausea and vomiting, sweating, and vertigo, which I figured at that point I was probably dying. But I ignored it for a little while as a classic bad doctor, and only came to emerge after a couple hours. So denial is very strong and great. Once I got to emerge, they did a troponin and an EKG, which were normal, and discharged me. When I was being discharged, my stubborn nature, and I guess some of my knowledge came out, and I refused to go, and asked them what was I going to do about the 8 out of 10 persistent back pain related to my dissection. Probably to get rid of me, they did a CT scan, and to everyone's surprise, and to my dismay, it came back positive. And I felt quite a difference here, that I different in opinion here, because it was great to know about this. I really thought, if I didn't know about this, I probably would have gone home and died. So it's an interesting experience. What I was diagnosed with was quite a big intramural hematoma, which then over a period of days became an acute type B dissection. And I lost several visceral arteries over the next week. thank heavens for collaterals, since I didn't develop any ischemic viscera. And again, as a patient, I was very relieved to know that there was a diagnosis and that I was in a very good place in CCU for care in case I ran into any other complications. At the same time, I was really anxious, and that's the part that knowledge, even knowing what was going on, I knew all the complications. It wasn't really a good thing to know all the complications, probably. And a little knowledge probably didn't help to me in that case. And I went through my classic Kubler-Ross. First, I was mad as hell that I'd got an aortic dissection. Then I was sad as hell that I had an aortic dissection, and then kind of resigned myself to my fate. And I must say, 12 years later, I still go through this. There's days that I'm mad. There's days that I'm sad. And most times I choose to live life, and knowing what I've got and knowing that my adventure isn't over. And I think it's very important to allow the patient to have these emotions. And as a physician, we're supposed to be in charge of our emotions, and we're supposed to be able to mute them all. You shouldn't have to do that. As a physician and as a patient, these are normal emotions, and I think it's very important to actually go through them. So I was discharged, and what I hear a lot of the times is, you're a doctor, you know what to do if you run into trouble, just let us go. So I wasn't initially referred to rehab or any type of much follow-up or anything. And when I got home, I was very anxious, that here I had this fresh aortic dissection. Would I run into problems? And again, it's important for a physician like me to be treated as a patient and assume that I know nothing, because as a patient with an acute aortic dissection, that was my first time. And although I know a lot about the disease, I didn't know how to do a post-aortic dissection event all on my own. Luckily, I got hooked up with the right places, and then we started the reassessment, where we watched it with MRIs and CTs. We measured, tried to see how fast and how large it was, and we waited. And we waited. And after 10 years of watchful waiting, I hit the target size, and the expansion rate actually had really accelerated as well. So just as this happened and we decided, well, we have to do something and have surgery at this point, COVID happened. And as department head in my department, I was busy getting testing and getting swabs out everywhere for the Eastern Ontario. So I had a lot on my mind besides myself, but COVID couldn't have happened at a worse time for me. That's funny. One of my slides isn't showing up. Well, what I had was a resection of my aorta from the dissection onward with a graft, a stent graft put in, and I did pretty well in the. It was a decision as far as the operation and everything that was done with a lot of sharing and with a lot of input, and I felt quite comfortable as a partner in making the decision. And I thought that was exceptional care that I'd received from my healthcare team. The post-op was very strange. I had auditory hallucinations, and again, I knew what every tube was, and I knew where every tube went. And as they came out, I could feel them, being pulled, and with the external pacer wires, pulling those and feeling them go through the skin and out of the right ventricle and the right atrium. It was an extremely weird sensation to have. A little knowledge was, I wouldn't say a bad thing in this case, but it was an interesting thing, to say the least. After my surgery, I was hooked up very well with online rehab since because of COVID, I couldn't do in-person rehab, and that worked fine. I had done the in-person rehab after my dissection with the track and treadmills and stuff. This time I did things online, and it worked just as well. And then we started into basically a watch and wait again. There was a bit of a little proximal endoleak that resolved itself, and we just went into CT scans. I retired, and it's important to note that I retired on my own decision. I didn't want to retire. Some people didn't want me to come back to work, and they said, "You're sick, you should stay away." Well, I retired, or I came back to work. I did a full work again, and then on my own terms and on my own time, I retired. I didn't want to retire with the label of sickness. And this was part, I guess, in getting my brain to realize that I still had a life to live and contributions to make. And I didn't want to go out being labeled sick. I had to retire. I chose to retire. And it was a very good decision. I developed a stent-induced neo-intimal tear again below my stent. And last year, I had TEVAR through my leg with an additional stent being placed. And of course, there were complications. Being a physician, we always get complications, it seems. I knew and expected and knew all of these. It still was disappointing to get them, but it just reinforced that, again, just because you know something doesn't mean that complications and everything are not going to get you. It did lead to a bit of a real decrease in quality of my life for a while, because I found it hard to walk with the complication I had. But that resolved itself, and I started in the watch and wait again, which is kind of where I am. The interesting thing that came back before the second surgery, but after my large surgery, is that they identified a mutation. Now, this is where we get into the should have, would have, could have. Should I have had a different operation? Would I have chosen that? Would they have even have been able to pick up the mutation in 2011? And I can debate that with myself all of the time. But my surgeon and I have talked, and we know what we probably would do going forward. And again, this was all part of a team decision, and I feel good that we made it. And success is that I'm still alive and have good quality of life. I do have residual disease, and I'm still at risk. And we watch and wait, and eventually, will we have to intervene? So in conclusion, being a patient was an interesting thing, probably something I would have rather avoided, but I didn't have that choice. I wasn't screened or anything. I presented with an acute event. And just because I knew a lot about it, it didn't necessarily always bring me calm. In fact, the opposite sometimes. And I often wonder, what if I knew nothing about this? Would I have gone home? And, people with acute dissections, would I have just ended up with a false lumen and asymptomatic, or would I have died? And that's something again that I don't have to debate too much, but the rectal spectroscope is always 100%, as we know. So I think it's important as healthcare professionals to treat the patient, even though they're a physician or a geneticist or whatever, and they know lots or anything, they need to be treated as a patient first. Control and loss of control is a real terrible thing because as a physician, you know, and I probably don't speak by myself here, but we like to be in control, and especially when we have opinions about what should be done. And you have to actually realize that you're not the treating physician in this case, and you have to allow yourself to be a patient. But I found this kind of a terrible thing at times, but I was lucky. I had an excellent healthcare team. So just a big thank you to my healthcare team. They were compassionate, and it really was a patient-centered partnership. Thanks to the genetic counselors and the laboratory geneticists that came up with what my mutation was. I think it's important to remember that no matter what you are, we all eventually probably become patients. And my journey is not unique. Huge thank you. And with that, I'll pass it on to my partner.
Fantastic, John. Thank you for that very personal perspective. I must say it's very special for the folks around the table here to hear that perspective of someone who not only has the specialized knowledge but has had the lived experience of going through something like this. So definitely a special part of this session. Thanks, John. Over to you, Ming.
Yeah, can you guys see the slides and hear me?
Yeah, all good.
Awesome. Thanks so much, Dr. Veinot, for your such a unique perspective and really interesting to hear your emotional journey as well through this. I'll switch gears a little bit to talk a bit more about the data surrounding this on the quality of life for patients with aortic aneurysm repair and follow up after aortic dissection as well. So there's two different disease process, similar but also different disease that we do follow. One is a aortic root or ascending aortic aneurysm, and the other one is aortic dissection, which is a consequence after having aneurysm for some time. The quality of life and the follow up for these two patients are in fact quite different. For patients with an aortic aneurysm, you think about the possibilities. Number one is a open repair, and number two is we kind of wait and see how things are. And unfortunately, sometimes aortic dissection does happen, and both things weigh on the patient's mind quite a bit. And because when you have open repair, what happens if you do have a complication, and as a result of that, you're not able to go back to the quality of life that you enjoyed before the open repair. On the other hand, if a repair doesn't happen or doesn't happen before the dissection occurs, then the dissection can certainly has a significant impact on the quality of life of patients. And essentially, having this idea of having a ticking time bomb in the chest of a patient can impact, or at least we think, impact the patient's emotional well-being as well as day-to-day activities by quite a bit. But there hasn't been a lot of data actually looking at this. There hasn't been a lot of studies really telling us how patients feel with a quantifying quality of life questionnaire. We have this study that we did through the Titan randomized control trial. As part of that, we have a registry of patients who underwent surgery or surveillance with aortic root or ascending aortic aneurysm between 5 to 5.4 centimeters. These patients completed a baseline quality of life questionnaire by this well-validated questionnaire called the SF-36. Now, the SF-36, just to do a quick summary, it looks at 8 different types of well-being indicators 4 indicates physical well-being and physical functioning, and 4 indicates mental well-being and mental functioning. And we essentially looked at the patients at baseline before there's surgery or before their imaging surveillance, as well as, and we compared it to the 1 year mark and compared the quality of life between the two groups. And we have about just over 200 patients, and 52 patients had surgery, and 100 patients were in the surveillance arm, meaning that they had imaging at 1 year. Of note, the surgical outcome in this case was excellent. There was no mortality, no stroke or heart attack, so no major complications. And the patient range is between 60 to 70 years old. When we match them, the two groups, in terms of their baseline clinical status as well as their baseline quality of life scores, you can see that from a baseline to 1 year, there has been, from a physical summary perspective, so from a physical health perspective, there wasn't much of a change between the patients who had surgery versus patients who had surveillance. And we really don't expect that there to be a change. If anything, the patients who had surgery were able to go back to what they were doing before, which is excellent. On the other hand, from a mental component part, we actually noted that for patients who had surgery, their overall mental health improved after surgery at 1 year, at the 1 year mark, compared to before the surgery, whereas patients who had surveillance imaging had a similar mental health between the two timeframes, which is quite interesting to see. I just like to quickly present here the spider plot here. So all the different health indicators are 8 different type of health indicators, physical or mental, are summarized here surrounding this plot. This is the changes between baseline versus 1 year quality of life scores in the surveillance arm. So you can see that it's quite it's around no change or zero change in most of the domains. On the other hand, in the patients who have surgery, there is, in most of the domains, there are some positive changes in terms of their overall quality of life well-being. And the ones that are specifically significant were their mental health scores, their social functioning scores, and their overall mental health well-being. So, when we think about when to do surgery or when to kind of continue to watch patients, aside from all these other factors that we currently consider, perhaps quality of life can be an indicator in the future once we have better studies looking at this area. And just a plug for the Titan SBS trial that we're running, where we are randomizing patients between 5 to 5.4 centimeters aneurysms to surgery versus surveillance. And we can certainly look at, once this trial is complete, we can look at their actual follow-up outcomes as well as quality of life outcomes in a randomized fashion. Now, just switching gears a little bit to talk about aortic dissections. Patients with aortic dissection after their initial dissection surgery are unfortunately most of them still have residual dissection and residual disease. And therefore, it is very important to continue to follow these patients and seeing how their dissection evolves over time. Now, this is a pretty recent study in 2021 looking at follow-up after aortic dissection in Ontario. And you can see that the Toronto group did this study. You can see that on the right-hand side here that really only about 15% of patients were consistently followed after their aortic dissection repair, and up to 85% of patients were not. And this can have significant impact on patient well-being on the long term. And the reason for that is that for patients who had these what we call guideline-directed imaging surveillance, that the reintervention rate at 10 years is about 17%, and survival at 10 years is about 70%. So it is very important to continue to follow these patients, and because their distal aorta can continue to dilate, and continue to require intervention to prevent future adverse aortic events. Thank you very much for your time.
Fantastic. Thank you, Ming, for that overview of quality of life in patients with thoracic aortopathy. I think we're a little tight on time, so I think we'll move directly to the next presentation and save all questions and discussion for the panel discussion that we have near the end. So I'll introduce the next speaker. The next speaker is Dr. Marina Ibrahim. She is an assistant professor at the Montreal Heart Institute, specializing in aortic disease. She completed her residency at McGill University and a fellowship in advanced aortic surgery at the University of Toronto, with dedicated training in both open and endovascular arch and thoracoabdominal surgery, aortic root reconstruction, and valve repair. She currently is an assistant professor and a program director of the Division of Cardiac Surgery at Université de Montréal. And she focuses on complex aortic aneurysms and dissection, and particularly the genetic aortopathy population that we're all so interested in. She will present to us about the state of the art in aortic repair in 2026. Marina, over to you.
Thank you very much, Munir. Do you guys hear me? Do you guys see my screen?
Yep, all good.
Perfect. Okay, thank you very much, Munir, for the introduction. Thank you, Munir and Julie, for inviting me to present today. So I changed the title just a little bit to talk about the state-of-the-art lifetime management of HTAD, because if it were up to me, I think, and to all surgeons, the ideal state-of-the-art management is really a Dacron metal jacket for all the dilated areas. So I'm going to include a little bit of lifetime management. I have no disclosures. So I'm going to start with a case, 34-year-old male with Marfan syndrome, found to have a PN1 mutation with a positive family history and systemic score of 8. Before his confirmed diagnosis. He was followed for severe mitral regurgitation with P2 prolapse, and also he had at the time a dilated aortic root at 44 millimeters. In 2017, he had a robotic mitral valve repair, then had to be taken back for a redo mitral valve repair by sternotomy. His last CT scan in 2020 had showed that he had an ascending aorta of 32, an aortic root of 46 by 44 by 44, with a left subclavian aneurysm that you could see sort of hanging at the end of the image in the scan, and thoracoabdominal aortic dilatation. He didn't really have a full thoracoabdominal scan, but you can also see sort of the thoracoabdominal aorta starting to dilate distally just above the celiac. So what are the next steps for this patient? How would you lifelong manage this patient? So the outline of my talk, I'm going to quickly go through initial assessment of these kind of patients, and I'm going to try not to overlap with Anne-Marie's talk, and review guideline-driven management very quickly, then review state-of-the-art surgical repair, and emphasize the importance of aortic team model and collaboration for these patients. So for us surgeons, I mean, there's multiple reasons, many reasons why you could have thoracic aortic aneurysm disease, but here we're focusing today on heritable thoracic aortic diseases, like Anne-Marie mentioned, whether syndromic or non-syndromic. Syndromic ones including Marfan's, Lois's, vascular erythrodermalus, non-syndromic mainly familial and bicuspid aortic associated aortic aneurysms. So in terms of incidence, 20 per 100,000 patients will have Marfan syndrome. Lois's incidence is 1 per 100,000, bicuspid 1,500 per 100,000. It's about 1% of population, and familial is 200 per 100,000. So why is it so important to early detect these patients? It's because unfortunately 40% will be presenting with a type aortic dissection due to the silent progression of the disease if we do not detect these syndromic aortas early. As much as size is important, and that's the only one we use right now to gauge our guideline as to when to surgically intervene on these patients, but definitely size does have limitations because a lot of these aortas will be dissecting at smaller sizes. Genetic testing is important, but unfortunately there are lots of variants of uncertain significance, like Anne-Marie mentioned, that complicate the risk assessment. And all of these patients do need specialized expertise and regular follow-up in centers of excellence with a multidisciplinary care to avoid having lots of misses like the patient that I'm actually presenting to you right now. So these patients do need a center of expertise to be following them, and we don't have these centers at every institution. So this patient here, the 34-year-old, had a dilated root, had his mitral valve repaired. Unfortunately, in 2023, did present with a type A aortic dissection. In terms of the initial assessment for these patients, what we do is clinical suspicion. When do we have a clinical suspicion? When a patient that's less than 60, like this patient, 34-year-old, presents with a type aortic dissection or an aneurysmal aorta with a positive family history and syndromic features, or sudden cardiac death in a relative, then that really raises the clinical suspicion for this patient. Then you get a detailed history and physical examination. And usually I refer to that for either Anne-Marie or Dr. Mangeon to do that detailed physical examination to diagnose these patients. Then once you have a high suspicion, you go for the initial imaging, which is usually a transthoracic echocardiogram to look at the root and the ascending aorta. And if there's a high suspicion there, then you go for the next step, which is a CT angiogram or an MRI. So transthoracic echocardiography is great for the root, for the ascending aorta as a first-line screening measure. But then if you need to do more holistic whole aorta measurement, then gated CT angiogram is the best, especially for pre-op planning, because you can do centerline measurements from the root all the way down to the iliacs. MRI is fantastic for long-term follow-up for younger patients where you do not want to expose them to radiation, and also for a comprehensive assessment. It's not great for surgeons because we really are not the best at reading MRIs, but it's fantastic if you want to follow patients long-term. So then Dr. Laberge already had touched down on the genetic evaluation, so I'm not going to get into that and who gets genetic testing. Then if there's a positive genetic testing or high clinical suspicion, then family will get screened. And then finally, the long-term follow-up. So the patient gets initial diagnosis, then you have the 6 months follow-up to repeat the imaging and establish growth rate. Then these patients will have their annual assessments with the physical exam and blood pressure management. Then the lifelong surveillance based on their aortic size, whether it's every year, every 2 years, or every 5 years even. So medical management is quite straightforward. It's systolic blood pressure wanted between 110 to 120. First-line medications, all these patients should be on beta blockers, then ARBs as an alternative or adjunct, ACE inhibitors if ARBs are not tolerated, and pregnancy obviously is high risk if the aortic root is more than 40 to 45 millimeters, and these patients need to be monitored closely if pregnant, and no ARBs or ACEs for these patients to avoid teratogenicity. So this is a very important question that all patients will be asking before surgery or even after the surgery if they have a dilated aorta that's left. And what I tell these patients, always light to moderate activity is recommended. They don't paralyze their lives. They just avoid competitive sports, isometric exercise, heavy weight lifting. As long as they can do the activity while talking and breathing, that means it's fine. If they need to hold their breath to do the activity, that means that raises their blood pressure, and that's not good. They shouldn't be doing too much of that. So when to plan for surgery? Anne-Marie already had touched on that. Very quickly, patient has a positive family history, more than 50 millimeters, unless patient has high risk features or an experienced team, that's a 2A guideline, then it goes to 45 millimeters. High risk features will include history of aortic dissection, sudden death at a family member less than 50, or rapid aortic growth. For syndromic patients, to each its own, and Anne-Marie already mentioned it. Then that was just the European guidelines, which pretty much says the same thing. Then bicuspid aortic valve 55, that's a class 1. More than 5 have high risk features, that is family history, rapid aortic growth, patients with a root phenotype or aortic coarctation. And actually the European guidelines will say the same thing. The new thing, the European guidelines, that it's a 2A indication at 52 millimeters for bicuspid valve for the ascending aorta. So surgical treatment, patient has isolated ascending aorta, very rare for patients with syndromic or heritable thoracic aortic disease. They're going to get an isolated ascending aorta replacement. We're quite aggressive with that. Then we'll do a circulatory arrest to really make sure we get all the way up to the innominate. These patients, if they have a dilated aortic root, then we will be preserving their aortic valve. This is very important. 2026, patients should not be losing their aortic valve. This is very, very important. So they will be getting a David procedure. It doesn't matter the way you do it, but at least it's the reimplantation, David reimplantation technique, where you stabilize the aortic annulus and you preserve the aortic valve. Bental, I mean, if most of these patients will actually have normal aortic valves, and this is the easiest valve sparing procedures. You'd be getting a valve sparing for whatever reason. If they get a Bental procedure, then also that will be replacement of the aortic valve, whether tissue valve or a mechanical valve, maybe in a dissection context where it's actually difficult to preserve the valve, dissect around the tissues, and an aortic center of expertise, and they will be getting a Bental procedure. For the arch, for these patients, we do not leave a float. We don't do an isolated arch replacement anymore, or leave a floating elephant trunk. These patients will get a frozen elephant trunk. That means a stent graft that is being deployed in their descending thoracic aorta, and a total arch replacement with Dacron. And a debranching of their head vessels in whichever way, multiple ways to do it. And they're going to be getting the replacement all the way down to the STJ. So this diagram is wrong. They're going to be replacement all the way down to the STJ, because if they don't, they can present with ascending aortic dilatation or dissection in the future. I mean, there are theories that say that patients that need thoracoabdominal, later reinterventions in the future, it's better to leave a floating graft, not a frozen elephant trunk. That is wrong, because it's actually does facilitate later procedures, which is an open thoracoabdominal surgery for patients with heritable thoracic aortic diseases. So you can actually clamp the FET, and it can make your thoracoabdominal a lot easier. Patients with thoracoabdominal aneurysms, depending on the extent of the thoracoabdominal aneurysm, they'll be getting their open thoracoabdominal repair. Type A aortic dissections, and that's my favorite pathology. Type A aortic dissections depends what the pathology. If it's mainly an arch, it's a patient comes in and you don't really know when they present whether they have a connective tissue disorder or not, because they present with the actual pathology. So if they're presenting with an arch pathology, then they're going to get a frozen elephant trunk. So root pathology, they're gonna be getting a valve sparing root. If they present with both arch and root pathology, then they're going to be getting both. So recommendations for extended arch and type A aortic dissections: if they have an aneurysmal arch, primary intimal tear in the arch or the proximal descending thoracic aorta, they have distal malperfusion. If they're young, probably connective tissue disorder, and if they have concomitant descending thoracic aneurysm, just to facilitate the future. So here, this is a case that I had done last week. 40-year-old male presenting with right lower limb weakness and acute renal injury. His Veinot was about 180 when he presented, and he couldn't move his right lower extremity. He had a scan, and he was found to have an acute type A aortic dissection with primary entry tear in the aortic root, with a root at 50 millimeters, as you can see here, and secondary entry tears in the ascending aorta and in the arch zone 2 and zone 3. And he also presented with distal malperfusion of the right renal and the right lower limb. You can see here there's no more flow in the right lower limb, or very decreased flow. So the plan for this guy was to get a total metal jacket from the front. So this is just the video on pericardial opening. Luckily, this guy was super stable. He didn't have any pericardial effusion. This is here the cannulation. I usually go central cannulation for type A dissections, just because it facilitates the surgery, and I make sure that I perfuse in the true lumen right away with guidance. Then for the cases that involve root and arch, I'm usually going to start while on pump before I clamp. I start with head vessels. So here, the carotid, left carotid had already been debranched, and this is a debranching of the innominate. I go as high as I can to normal, as normal non-dissected portion of the innominate. And then here, this is on circ arrest. I deployed the frozen elephant trunk. This is the frozen elephant trunk here. This is a stent in the subclavian just to facilitate the procedure to avoid branching it. This is the distal anastomosis here. This is the arch. And this is the frozen elephant trunk deployed in the arch, in the distal arch. This is just the Dacron graft that we're sewing to be replacing the proximal arch and the ascending aorta. Now to the root, the entry tear you can see right here was in the non-coronary sinus, and this is just here starting the root dissection. Then this is after the entire dissection was done, the right coronary artery is there, the left coronary artery is there. Then this is after the reimplantation procedure was done, and after the coronary reimplantation. Usually the valve sparing procedures here are quite straightforward. The valves are not pathologic. They're very easy to preserve. And here, this is the final result with the innominate debranching. Carotid was right there, and the valve sparing here, and the frozen, you don't see it. So this is the results for this patient. He fully recuperated. His renal malperfusion and his the right lower limb malperfusion, and here there's his echo result, no OI. So before I end, I just quickly going to go back to our first index case, our 34-year-old male with Marfan's, who had his robotic and reduced sternotomy mitral valve repair. Then had, for the type A dissection, he had a third reduced sternotomy for valve sparing root replacement. And again, his mitral valve had to be repaired at the time. Then he was referred to me in clinic for subclavian aneurysm that's at 34 millimeters, and slight arch dilatation 42 by 35 millimeters. And he had also a suprarenal abdominal aortic dilatation that's not evident on this scan here. So what does this patient really need? He finally needs an aortic team with coordinated multidisciplinary care. Since this patient was referred to the aorta clinic, I found that now he has a few issues. He has had his mitral valve repaired 3 times. He's just had his type A aortic dissection repaired with a valve sparing root, but then now he has a huge subclavian aneurysm that needs to be dealt with. His arch is not surgical yet, but after multiple discussions with his cardiologist, with the vascular surgeon, with myself, we had a holistic team approach discussion, and then we decided that just better to deal with his arch at the same time to avoid a 5th reduced sternotomy for his arch. The summary here: 34 Marfan, subclavian aneurysm, arch 42 with residual dissection. We decided to do it all. So he had a right carotid to axillary bypass, right vertebral to carotid transposition with ligation of all the subclavian branches by the vascular surgeon, and ligation of the proximal subclavian artery, which made the surgery a lot easier. Then he had his reduced sternotomy, central cannulation, debranching of the right and the left carotid arteries. And this was the subclavian aneurysm here that I just simply ligated, and that was the remnant. And then he had his frozen elephant trunk at the same time. So he did very well post-op, and I promised him, you have a few years break of me now. Unfortunately, his cardiologist contacted me 3 months post-op in his post-op scan and told me that his abdominal aorta, thoracoabdominal aorta had grown to 50 millimeters. So a year later, he had his type 3 thoracoabdominal repair that I just did last week, actually. He's extubated and he's getting discharged. As extubated day 0, and he's getting discharged today as we talk. So he did very well. Now, for real, he has a few years break. Summary, HTAD requires lifelong multidisciplinary team-based care with regular surveillance and targeted interventions. Treatment does not end with surgery. It needs continuous monitoring and adaptation of care plans throughout all life stages. And aortic team model optimizes outcomes through collaborative care and decision-making, and really complex decisions require multiple perspectives. So I'm just going to end with this from the Montreal Heart Institute. We have the Aorta app in collaboration with the Canadian Thoracic Aortic Collaborative, the Lois Leeds Foundation, and ourselves. So this app is we're launching it in the next few weeks. We're just doing the final touch-ups. So this app is going to be very helpful for family doctors, for cardiologists, and even for cardiac surgeons to gauge the management of patients with aortic pathologies. You basically put the patient age, the patient aortic diameters, and it displays out for you the latest aortic guidelines with American, European, and when to do this, when is the surgical intervention is indicated. That's it. Thank you very much.
Fantastic. Thanks, Marina. That was a really whirlwind overview all the way from aortic valve down to the iliacs. So thanks for that very nice overview. We'll move to the next talk. Julie, over to you.
Thank you, Munir, and thank you, Marina, for this tour de force. So our next speaker is Dr. Michelle Keir, who is an adult congenital cardiologist at the Libin Cardiovascular Institute in Calgary. She's also the medical director of the heritable aortopathy cardiology clinic at the University of Calgary. And I had the pleasure of meeting Michelle when she was the co-chair and invited me to participate in one of the papers that Marie talked to you about. So Michelle will talk to us about the do's and don'ts of pharmacotherapy for this group of conditions. So thank you so much, Michelle, for being with us.
Okay, thanks. Can everybody see my slides?
Yes, they show up
Okay.
just perfect.
I'm not sure how to take it off the notes view.
We see the presenter mode, so we see what we're
Okay,
supposed
perfect.
to see.
Okay, good. Okay. So thank you so much to Munir and Julie for inviting me. It's a really interesting session. So I'm going to talk about the do's and don'ts of pharmacotherapy in heritable aortopathy. So my conflict of interest, I have received competitive research funding from the Louise Dietz Foundation of Canada, and I'm a medical advisory board member of GATA and of Louise Dietz Foundation of Canada. So what are the cardiac manifestations of Marfan syndrome and related disorders, aside from just the descending aorta, and can we prevent some of these complications with medical therapy? So we often see, in addition to the dilated aorta, mitral valve prolapse, mitral valve disjunction, dilated mitral annulus, and regurgitation. We often see tricuspid valve prolapse. Some of these patients have significant tricuspid regurgitation as well. We tend to focus on the left-sided valves, but we shouldn't forget about the right-sided valves. Obviously, dilation of the aortic root resulting in aortic regurgitation and dissection that we've talked about quite a bit today. There's also a significant in Louise Dietz syndrome and other disorders risk of vertebral artery tortuosity, and oftentimes these patients will present with dissection of a vertebral artery. And then also there's the risk of visceral aneurysm, specifically in Louise Dietz syndrome and vascular Ehlers-Danlos. So these are kind of the dreaded complications. Can we prevent any of these things with medical therapy? So the thing that we commonly think about is Marfan aortopathy, and this is kind of the most dreaded complication. So when we think about this, most patients are born with some dilation of their sinus of Valsalva, and the rate of progression is very variable. So recognizing the subset of patients at risk for aortic regurgitation and dissection exceptionally difficult. So we have some families where they all have the same gene with significantly different penetrance, and we have some that are 80 years old and they have no aortic dilation, and then a 20-year-old family member with the same gene who has significant aortic dilation. So who should we really be targeting for medical therapy, and how aggressively should we be titrating? Aortic regurgitation is often present when the aortic root diameter is greater than 1.5 predicted for body size, and 90% of deaths in Marfan patients before current surgical techniques were due to proximal aortic dissections or severe aortic regurgitation. That phenotype has changed significantly since we do have genetic testing in many of these patients, and we're able to catch them before they get to that point. So some of the other complications are rising to the forefront. And the earliest pathologic sign of Marfan aortopathy is cystic medial necrosis as a marker of chronic injury and repair. Although it's important to note that's not pathognomonic of Marfan syndrome. So oftentimes we'll get an autopsy report and it'll say cystic medial necrosis. So we get a referral on that dissection patient, and it's not necessarily pathognomonic. So again, this is just some imaging of that dreaded complication that we're trying to prevent. So A is the dilated ascending aorta, and B and C show the dissection there. And this is the histologic degeneration of aortic tissue that we see progressively in Marfan syndrome. So disarray in the extracellular matrix, shrunken smooth muscle cell fibers, thickened basement membrane, and abnormality of the collagen fiber structure with progressive fragmentation, which eventually ends in dissection. So can we prevent the most dreaded complication of HTAD with medical therapy? Or are we just, as one of the fellows said, just the aortic measuring clinic and then we send them to surgery? Or can we do anything to modify this with medical therapy going forward? And this is a picture of not a patient of mine. It was a patient in Toronto. It was a case report from Jack Coleman many years ago. But this is a woman who had Marfan syndrome, who had a aortic root repair in advance of pregnancy, and then had a twin pregnancy, and unfortunately had a type B dissection from the suture line all the way down in pregnancy. And so this is the thing that we're all kind of most afraid of. And can we prevent this from happening with medical therapy? So the thinking about how aortic dilation progresses. So you've got in the center, your endothelial and vascular smooth muscle matrix, which is disorganized because of the underlying genetic abnormality. And it's kind of a closed loop system. So you have hemodynamic stress from high blood pressure or isometric activity, which then mechanotransduces to cause histologic abnormalities. With those histologic abnormalities, you get progressive dilation and wall thinning, which then causes more hemodynamic stress. So once you get into this difficult cycle, it's hard to get out of it. And is there anything we can do to modulate this? So medical management. So the initial thing that we always talk about, and this is in all the guidelines, is beta blockade in Marfan syndrome. And we extrapolate this to all other heritable thoracic aortic disorders. The original trial was in 1994, and it only included 70 patients with a clinical diagnosis of Marfan syndrome. So some of them did not have genetic testing. They were randomized but open label to either beta blocker or no treatment. Importantly, patients over the age of 50 were excluded, as were those with at least moderate AR. So that's kind of a large portion of our patient population. Those in the treatment arm received propranolol, which is not a beta blocker that we would currently use in contemporary practice for cardiac reasons. And they titrated to a heart rate of less than 100 with exercise and a systolic BP of less than 160. And the follow-up averaged 10 years for both groups. And you can see in this slide, so the top group there is the control group and the bottom group is the treatment group, although it was open label, but there was a significant difference in aortic dilation ratio and time of dilation over that 10 years. There wasn't a significant difference in mortality, but this is the data that has borne the recommendation that all patients with Marfan syndrome and related disorders be on a beta blocker. So beta blockers, so recommendations in Marfan syndrome, beta blockers for all, titrate to a resting heart rate of less than 60, yearly echoes for assessment of aortic root size, and that imaging should become more frequent if their size is getting close to a surgical dimension. Again, no static isometric exercise, and we're avoiding bodily collisions. What are challenges to beta blockade in real world practice? So we see this quite often, that the recommendation is they should be on a beta blocker, but often these are really poorly tolerated in young women. So I have lots of young women that I'm starting, 1.25 of bisoprolol on, and they call back and say, I'm having vasovagal syncope, I can't take this medication. POTS, or postural orthostatic tachycardia syndrome, is often also common in this patient population, as is autonomic dysfunction. And so it often limits our uptitration of medication. The reduced rise in heart rate with exertion is difficult for our endurance athletes. So we always tell these patients, we want you to be active, but we want you to avoid heavy isometric exercise. So things like running, swimming are excellent exercise for your heart, but then we put them on beta blockers, which for young patients can really reduce their ability to participate in these endurance activities. Again, indicated in pregnancy for prevention of aortic root dilation in those with Marfan syndrome and related disorders. But often I get told by patients, well, I went to see my pharmacist and they said, well, there's the risk of intrauterine growth restriction, so I don't want to take this medication in pregnancy. So these are all some of the challenges that we hear in real clinical practice about getting patients on these guideline-based therapies. So what about ARBs and what's the evidence for that? So this was in kind of the late aughts where there were some mice studies that showed that ARB was superior to beta blocker because of TGF-B signaling in young adults and adults with Marfan syndrome. So this was one of the seminal trials. And the basic hypothesis was that a genetic deficiency of fibrillin-1 leads to decreased binding to TGF-beta receptors and increased TGF-beta signaling. So if we can suppress that signaling with a medication like an ARB, then we may have a significant benefit over the hemodynamic benefit of beta blockers. In real world practice, though, and in randomized controlled trials, so this was a randomized controlled trial of losartan versus atenolol, and there were similar trials, in older adults and adults with Z scores that were greater than 3. The primary outcome was rate of aortic root enlargement over a 3-year period, and the secondary outcomes were rate of change in aortic root, death, surgery, and aortic regurgitation. And so this trial had 600 participants, and many centers across North America, so wide inclusion, and the randomization was done very well. And so the results were that there was no significant difference between the control and treatment groups in any pre-specified outcome, no significant difference in compliance between the two groups, so that comes into play when we talk about beta blockade, and no significant difference in annual rate of change. So these trials answered the questions for us, is ARB superior to beta blocker? But it never really answered the question, is beta blocker really superior to placebo? And is additive therapy beneficial? And this is just the results of that, showing that the two arms really align closely and there was not a significant benefit of ARB over beta blocker. So the question remains, is additive therapy beneficial? So we have no RCTs comparing additive therapy to single agents. Theoretically, we think it would be beneficial because ARB and beta blockade have different mechanisms of action. So ARB decreases pulse wave velocity and stiffness indices of and the beta blocker decreases the power of contraction and the power over unit flow in the aorta. So we think that combining them is beneficial, but we don't have great data to show that that's the case. And again, with ARB, so one of the other speakers mentioned that it is teratogenic, and so it's something we want to avoid using in women of childbearing age, and that is a large proportion of our patient population. So what about other things and things that we should potentially avoid? So there has been some data published on the risk of calcium channel blockers in those with Marfan syndrome and other aortopathies. So in Marfan mice, calcium channel blocker, and that was amlodipine, accelerated the rate of aneurysmal growth and the risk of aortic dissection in mice. Importantly to note is that the dose utilized in these mice was 12 milligrams per kilogram per day, which is quite high. They tried to reproduce the results with a dose of 3 milligrams per kilogram per day, which is still significantly higher than we would use in adult humans, but they found the same benefit. So observational data from the GenTech registry showed greater odds of aortic dissection and or prophylactic aortic surgery in patients treated with a calcium channel blocker. So essentially, there's no definitive data to say that we should not be using calcium channel blockers in this patient population, but caution should really be exercised, and it should be kind of our last choice. Importantly, in these patients, especially the ones that have had lots of surgery and they have lots of graft material in their aortas, it's very difficult to manage their blood pressure. They're often quite hypertensive. And so sometimes we do have to use a calcium channel blocker if we've maxed out on all of the other therapies. But the goal is to not use that in patients with a significant proportion of native aorta still present. Similar advice for fluoroquinolone use. So again, if we look at kind of general recommendations, the thought is that those at high risk of aortic dissection should not be prescribed fluoroquinolone. And again, this is from large epidemiologic studies. No real great data in patients with heritable thoracic aortic disorder. But if we can, we avoid using these because there is a potential for dissection in those that are at greater risk. And so my time is just about up, but I wanted to end with the Think Aorta campaign. So this actually started in the UK. And I think when we talk about pharmacotherapy and medical therapy, we often think about medications and surgery, but we don't often talk about education for patients with known thoracic aortic disease. And it's a really important modifier of how patients do and outcomes in this patient population. I think the patient perspective is very important. So we often hear the same story that we heard earlier today, that the patient goes to the emergency department with severe chest pain. They get troponin, they get an ECG, they say everything looks good, you can go home, and a CT scan is not performed. And often patients don't have the efficacy to advocate for themselves. And so this is a really important campaign, that in young women, young people, an aortic dissection is still quite a prevalent diagnosis, and the index of suspicion needs to be high, especially in the setting of a family history or prior imaging showing some aortic dilation. So I'll stop there. Thank you very much.
Thank you so much, Michelle. That was really useful, and thank you for showing us the data. That was a great talk. Does anybody have questions for Michelle, or actually for any of the other speakers, since we have 10 minutes for a panel discussion? If nobody has any question, I have one. We hear different numbers in terms of what a target blood pressure should be. We used to say 130/80 at our clinics in Ottawa. I saw that Marina had 120/110 of systolic. I was wondering if maybe both Marina and Michelle could comment on the level of evidence that they've seen for those numbers, what they do in their practice, why, etc.
Yeah, I would just say, I think, like a lot of things in rare diseases, the level of evidence is not great. We tend to target less than 125/85 at rest, and a systolic blood pressure of less than 160 at peak exertion. So if we're doing a treadmill or a CPET, that's the goal that we're going for. Again, those numbers are not based on robust RCTs, but kind of more clinical gestalt, but that's what we aim for. And in young patients, yes, beta blockers and or ARBs are indicated, but it's often difficult because they are hypotensive at baseline. In older patients that have had surgical repair, they tend to be hypertensive, so we can actually get them on target medications much easier. But then it gets to the point of, are we actually reaching the target, and do we have to add other agents in? But those are the numbers that we use.
Thank you. That's interesting, because you have not quite the same number as what we've been using in Ottawa, and I'll let Marina comment, but not quite the same number than on her slides either, which illustrates what you led with, that they're rare diseases and everybody does their best, but with, unfortunately, often a paucity of data. Marina, did you have anything else to
Marina just informed me that she lost her connection, so she's going to see if we can join again. But you know, we do have a few questions in the chat that are coming through. I just want to invite, for the next few minutes that we're on the panel discussion, if you guys are in a position to turn on your cameras, please do so. It makes it much more interactive for all of us. We get to see you. There are a few questions. I'm going to go from the top here. There's a question from Catherine Armstrong. What do you think about the potential impact of ARBs on other systems? Example, scoliosis and Marfan's, you know, possibly back to the mice. Or do you change your recommendation based on the haplotype insufficiency, dominant negative genetic mutations? Yeah, go ahead. Whoever wants to tackle that one.
So we don't. We generally kind of take advice from our genetics colleagues that if they have Marfan syndrome or related aortopathy, we want them on either a beta blocker or an ARB or additive therapy if we can get them on it. But Julie, I don't know if you would comment on targeted therapy or targeted pharmacotherapy. I don't think we're at that level of evidence yet.
We don't in our clinic. However, what we do differently is for kids who did not yet dilate, our pediatric cardiologist is significantly more aggressive about initiating pharmacotherapy if it is a protein truncation variant. So for for an FBN1. So because these are known to be associated with a higher risk of aortic event, often pharmacotherapy will be initiated with for those kids, even in the absence of aortic dilation. So there is a little bit of that, but Anne-Marie, I don't know if in your clinic you do something different.
No, I think it's similar, but I think the question was also about the potential impact on other systems like scoliosis and other symptoms, and I don't know of any known impact, on other symptoms. Yeah.
No, the only thing that I know is hypothesis in the literature is agents that have a strong anti-inflammatory effect, and that might be beneficial. But again, there's some degree of evidence in degenerative aortopathy, then adding a statin helps to protect, and whether that will also be true in heritable aortopathies, that might be the case. The mechanism makes sense, but we don't have the data yet.
Fantastic. There's just, I'll just read from the chat. There's a couple of the questions around beta blocker, ARB, and calcium channel blocker use. So I think all directing towards Michelle. Do you use both in your patients with aortopathy? How often are you able to use both? Are we using beta blockers and ARBs in patients with LDS or EDS or any other aortopathy? So let's say if it's not those specific syndromes. Maybe comment on that, Michelle.
Yeah, so I think, sorry, I put in the slides a lot of Marfan aortopathy because that's really the only data that we have, but we extrapolate that for all of the heritable thoracic aortic disorders. Whether that's correct or not, I'm not sure, and hopefully we get more targeted data as genetic testing becomes more widely available and we get more people with unique variants and we can target pharmacotherapy to those unique variants. But right now we use kind of a standard approach for Marfan in anyone with heritable thoracic aortic disorder. And yes, we always try to use beta blocker and ARB if we can. Again, in younger patients, it's a real challenge, and women of childbearing age that aren't on adequate contraception, that's a whole other conversation. Then we avoid ARBs because of the risk of teratogenicity. And again, for calcium channel blockers, it would be the same. We only have data from Marfan mice and from the Gentech registry, but so we say that the recommendation is that you try to avoid calcium channel blockers in anybody with a heritable thoracic aortic disorder. But as I showed, the data is not great. And sometimes we do, because they are so hypertensive and have lots of graft material, need to use some calcium channel blocker to get them at target. And so we do occasionally do it, but it would be kind of the last line agent. And sorry, there's another question about monitor BP during exercise. That's a really important question. So, especially with the age of wearables and people using their Apple Watches and that sort of thing, we usually do post-op a stress test to see during rehab to see what their blood pressure is when they get to peak exercise. And we're actually looking at developing, my colleague here in Calgary, Erin Carlstead, who does rehab and who's also helping in aortopathy now, is looking at doing stress tests on many of our patients because we want them to be confident exercising and knowing that their blood pressure will not rise too much. And so the idea is to do some stress testing so we can then provide guidelines.
Fantastic. Great conversation so far. There's a question that maybe I'll direct towards our surgical colleagues. We are trying, as you look at the guidelines progressing over the years, the threshold for intervention on genetic aortopathy is dropping lower and lower. And some of it is very targeted based on, the specific syndrome or specific gene. And some of it is a bit more generic. Even in degenerative aortopathy, the guidelines have shifted leftwards. But then there's a body of literature that's emerging that says, well, if you replace the aortic root, you transfer some of the pressure buffering capacity of the aorta, the stresses go more distally. And there's some data to suggest that, root replacement early leads to a higher incidence of type B dissections downstream. So I don't know if the panel wants to comment on some of this new literature. Should that be factored in to our very young patients in whom we're now giving them a fairly non-expansible aortic root with surgery? Should we treat their downstream aorta any differently? Ming, any thoughts on that, or anyone else from the panel?
Yeah, thanks. I think the you know, as we review these literatures, there's remains quite a bit of limitations about the way that studies conducted and the patient population that's out there. There are certainly some evidences from a biomechanical perspective that could explain it, but I think survival bias and survivor bias and patient population that were being followed can also potentially contribute to these results that we're seeing in these populations. So I personally think it's a bit hard to say right now whether we should include that in our day-to-day decision making. I think we are still very much with practice based on the current guidelines and the current recommendations, but this should definitely be looked into from a biomechanical, but also from a population-based perspective to see what the true impact is. Right now, I'm not entirely convinced.
Thank you very much. And thank you so much to all of our speakers and to all of you for joining us this afternoon. It was truly a pleasure to see you all. I hope that we can continue to work together as a community and work and learn from one another. Unfortunately, we are not allowed to keep you for the rest of the afternoon as there are other sessions in the conference, and some of you may want to attend those. So we'll have to wrap up. If there's any other questions, please don't hesitate to let us know. And again, a huge thank you for all of you for sharing your expertise and making time in your schedule today for us.
Thank you, everyone. Great to see all of you.